Hey guys, so today I'm going to be talking about neurodevelopmental therapy, or NDT. So the learning objectives are to understand and be able to discuss the theoretical basis of NDT, understand and be able to discuss the concepts and principles behind NDT, understand and be able to apply various strategies and techniques used in NDT, and finally, understand and be able to apply NDT evaluation and treatment. So first I'll start off with some history about the approach. Originally called the Bobath approach, NDT was developed by Carol and Berta Bobath in the early 1940s. It was originally developed for the treatment of hemiplegia caused by cerebrovascular accidents or stroke. Later on in its development, it was also used as a treatment for cerebral palsy in children. Today, NDT is used to treat a wide range of health conditions affecting motor control in both children and adults, and it's the second most used frame of reference by OTs in the U.S. So Carol Bobath was a neurologist and Berta Bobath was a physical therapist. Not surprisingly, the theoretical concepts of NDT came from neurology, medicine, physical therapy, and studies of human development and brain injury. It is considered a neuromaturational or reflex hierarchical approach, which bases both acquisition and recovery of skilled movement on the developmental sequence of mastery over primitive reflexes. To put it more simply, NDT is based off the theory that both motor development and motor recovery occurs in a sequential fashion, starting with primitive reflexes and then evolving to perform more complex movements. As a result, NDT is considered a preparatory treatment because it is directed towards establishing sensory motor performance components that are prerequisites for occupational performance. So now we'll talk about some assumptions of NDT. Number 1, motor control progresses from head to foot, from trunk to limbs, and from large to small. 2, children gradually gain control over primitive reflexes based on sensory input in order to perform skilled voluntary movement. 3, children internalize the sensation of movement, which creates motor sequences or patterns of movement, which are internalized sequences of stability and mobility. Some examples of these patterns are rolling, sitting, crawling, standing, and walking. 4. In recovery of movement, proximal stability leads to distal mobility. Stability is created by co-contraction of opposite muscle groups, thereby holding the body in place and mediating the effects of gravity, which makes skilled movement possible. Mobility is the ability to move around freely and represents a way to engage the environment through purposeful voluntary movements. 5. Following a brain injury, abnormal movement and tone must be inhibited before normal movement and sensation can be restored. This is because if the central nervous system continues to receive abnormal sensory input, this will cause abnormal sensory feedback, which will result in abnormal motor pathways being reinforced. 2 types of abnormal movements identified in hemiplegia are flaccidity, which is limpness or low muscle tone, and spasticity, which is high muscle tone that results in stiffness and involuntary or spastic movements. 6. Splinter skills are motor skills which are learned by rote and out of normal developmental sequence. These are skills that are mastered before they are developmentally expected and are not recommended in NDT. An example of a splinter skill would be the ability to play a particular piece on the piano without having the generalized ability to play the piano. Function and disability. So function refers to the capacity to perform voluntary skilled movements needed for everyday life. Children are considered to have motor dysfunction when they are unable to control their own movements. This may be caused by lack of neural inhibition or the persistence of the child's primitive reflexes. Common dysfunctions seen in children with cerebral palsy include lack of postural control, abnormal tone, generalized spasticity, poor inhibition of non-functional movements, and sensory disturbances. Some disabilities commonly identified in stroke survivors and treated using NDT include loss of postural control, including the inability to stabilize one's position at rest or during movement, and an example of this would be a client with hemiplegia following a stroke, who may be unable to shift their weight while standing and may lack the necessary equilibrium responses to maintain their balance. Loss of selective movement control, usually on the side of the body which is opposite to the site of the brain lesion, and this often leads clients to use one-handed techniques for task performance, which NDT seeks to avoid. Abnormal tone on the affected side, leading to flaccid or spastic tone, resulting weakness or stiffness, and difficult or inefficient movements. Involuntary non-functional movements on the affected side when moving the unaffected side, poor inhibition of primitive reflexes and/or non-functional movements, and lastly, sensory disturbances which contribute to abnormal movement patterns. Change and motivation. So change in NDT occurs through application of specific techniques and strategies, including handling, placement, use of facilitation and inhibition techniques, and using reflex inhibiting patterns or postures, also known as RIPs. So handling is a strategy that addresses issues with tone and movement control. For this technique, the occupational therapist places the client in positions that decrease spasticity and activate normal movement patterns. Initially, the OT guides client movements to retrain specific muscle groups. The goal of this is for the client to experience what normal movement feels like. In turn, tactile, kinesthetic, and proprioceptive messages help organize client movement and influence muscle tone status. The placement technique refers to the occupational therapist placing their hands on key points of control, or the points that have the most influence over client movements. Proximal points of control influence stability in the trunk, shoulder girdle, and hips. Distal points of control guide the positions and movements of the arms and legs. The goal of the placement strategy is to inhibit abnormal movement and to facilitate normal movement. During facilitation techniques, occupational therapists will provide clients with the sensation of normal movement, direct muscle stimulation, and a system for learning normal movements of the trunk, arms, and legs. Therapists will assist clients in practicing normal movement while holding or restraining certain areas to restore alignment, and teach clients to use the same restraints when performing daily tasks and occupations on their own. During inhibition techniques, OTs will teach the client methods to prevent abnormal positions and postures. They might also lengthen spastic muscles and position the body in a way that decreases excessive muscle tone. Reflex prohibiting patterns or postures refer to positioning clients in ways that reduce tone by inhibiting certain primitive reflexes. One example of this is inhibiting the tonic neck reflex. This reflex can be inhibited by turning the client's head away from an extended arm, which in turn reduces tone in that arm, allowing it to move more freely. Motivation is not addressed specifically in NDT because it is assumed that treatment will result in spontaneous improvements without much effort from the client. However, clients may be more motivated if the functional movements they practice relate to activities that are meaningful to them. Okay, so now we'll talk about evaluation. NDT evaluation involves both observation and handling in order to assess and record functional movement capacities and limitations. During the initial observation, the OT will note typical postures, preferred movement patterns, spontaneous use of the affected side, and compensatory strategies that are already in place. Handling, which was mentioned in the previous slide, is typically performed on a mat, during which the OT looks for several general observations, including the client's response to being moved, normal or abnormal tone, movement on the affected side, response to sensory input, and assessment of strength and movement control. Specific handling includes posture and movement sequences that relate to occupational performance. During this, the OT will look for trunk movement, response to weight bearing and weight shifting, spontaneous equilibrium reactions, which are reactions due to changes in the client's center of gravity, and protective responses while sitting or standing. In addition, selective control of arms and legs is evaluated segment by segment, moving proximal to distal in order to assess segmental movements, quality and strength of movements, and effective muscle tone on movements. Evaluation also includes collaborative goal setting with the client and their family. An example of a functional goal they might come up with is increasing independence in self-care and mobility. Guidelines for intervention. Initial goals for intervention vary depending on the client's condition, motivation, and occupational preferences. Initial movement training is practiced using occupation as means, and the occupations used are structured to include specific movement strategies. A couple examples of these strategies would be weight shifting and trunk realignment during transfers, and bilateral arm use in wheelchair management. NDT discourages compensation with one-hand strategies for task performance, as it is considered counterproductive and encourages learned neglect. During treatment, clients should be encouraged to use the injured side for ADLs and aim to achieve occupational goals such as increasing balance and postural control during daily activities. When working with stroke survivors, OTs are advised to always check for shoulder subluxation before practicing any arm movement. Shoulder subluxation is common in stroke patients due to either the muscles being too weak to hold the shoulder bone in place or muscle spasticity, which may pull the bone into an abnormal position. In these cases, it is important to manually restore normal alignment of the joint and use modifications during treatment to prevent further injury. Interventions for children with developmental disabilities starts with handling using inhibition and facilitation to encourage normal movement. Guidelines for children include engaging the child in using sensory input and using sensory inputs that either facilitate or inhibit muscle activity, encouraging co-contraction of postural muscle groups for stability, moving selected body parts as the child interacts with objects or others, propping or positioning to assist with weight-bearing tasks, use of supportive devices or equipment to control alignment and facilitate functional movement, and teaching family caregivers any necessary strategies for ADLs. Alright, so now we'll talk about the research behind the NDT model. So Charles Sherrington, a famous neurophysiologist, first called attention to the reflex model in 1906. He hypothesized that all human movement consists of a combination of reflexes triggered by specific sensory input. Margaret Rood, who is listed as one of the 100 influential people in OT, based many of her facilitation and inhibition techniques on this concept. As a result, reflex testing became a standard method of assessment. The hierarchical model, which was first developed in 1932, suggests that movement is controlled by the central nervous system in a top-down fashion. Schmidt, one of the researchers behind the model, hypothesized that motor programs are stored in the central nervous system, containing instructions for responses to specific input. The NDT approach is consistent with this model, which views abnormal movement as the loss of voluntary control in the central nervous system. However, in the past 25 years, motor learning research has questioned the validity of the reflex and hierarchical models, based on growing evidence that multiple characteristics of the person, task, and environment contribute to motor control and recovery. This has led to a proposal of a contemporary task-oriented approach for movement dysfunction. So lastly, I'll be discussing the peer-reviewed article that I assigned, which examined the effect of intensive NDT in gross motor function of children with cerebral palsy. The participants were 34 children, 12 females and 22 males, ages 3 to 14, with mild to moderate spasticity and hemiplegia, diplegia, or tetraplegia. The purpose of the study was to evaluate the effectiveness of NDT on gross motor function in children with CP and particularly to investigate the effect of intensive NDT intervention compared to a less intensive intervention. For the methods, participants were randomly assigned to one of two groups. Group A underwent NDT 2 times a week for 16 weeks, and Group B underwent NDT 5 times a week for 16 weeks. Treatment was individualized for each child and based on their unique clinical needs. The differences in treatment were based on the variations in severity of each child's condition, not differences in therapist techniques. The outcome measure used was the gross motor function measure, which assessed the performance of participants before and after intervention. And finally, the results were that the gross motor function of both groups improved significantly from intervention, but Group B performed better and showed significantly more improvement than Group A, supporting the effectiveness of NDT and the need for intensive application of treatment. And lastly, here are the references I used. Thanks for watching.